Good morning, and welcome to day 4 of the Justice, Reentry, and Healthcare Summit, coming together for social justice in socially distant times. On behalf of Jane Shull, CEO of Philadelphia Fight, the Board of Directors, my staff, and myself, Asada Thomas, Director of the Institute for Community Justice, I extend greetings. The overarching theme for this week is the acronym CITE, C. Imagine, grow, heal together. Every webinar and every guest speaker was selected with intentionality on educating, empowering, and in a call to action for social justice in various spaces. On Monday, C, we had our opening plenary. On Tuesday, Imagine, we had Dr. Jacqueline Bailey Davis of the Philadelphia Police Department and Angeline Dean, who spoke about the history of education and the school to prison pipeline. Yesterday, Grow. We heard from the Public Defender's Office and how to navigate the current judicial system and a host of other valuable information in navigating the new norm. We then heard from Dennis Febo on the Amend the 13th movement and Mr. Donald Dinks on voting rights. Thus far, it has been a powerful few days, and we are not finished yet. Today's theme is heal. In our morning session, we will hear from our very own Dr. Stacey Trooskin, Chief Medical Officer at Philadelphia Fight, along with Kevin Costello, her colleague. Since our theme today is heal, it is only befitting to have the Chief Executive Officer of Philadelphia Fight, Jane Shull, introduce the first session of the day. Jane is at the helm of Fight, and it is as a result of her commitment, advocacy, activism, and determination in demanding social justice for HIV that the Institute for Community Justice was subsequently birthed, and thus its commitment to social justice in mass incarceration. In order to understand your now, you must understand your history. Allow me to introduce our CEO of Philadelphia Fight, Jane Shull. She is an executive director, as I said, where she has worked for over 20 years. In this role, she has overseen the expansion of Fight from a small startup nonprofit to a comprehensive healthcare services organization providing primary care, consumer education, research, and advocacy for people living with HIV and AIDS and those at high risk. In the early years of the AIDS epidemic, Jane was involved in activism with the ACT UP Philadelphia. Prior to her work at Fight, she worked at the Institute for the Study of Civic Values, developing programs to empower low-income communities to take charge of their own futures. Jane has taught at the Temple School of Social Administration and at the University of Pennsylvania Urban Studies program. She is my direct report. She is the helm of Philadelphia Fight. I introduced to you some for the first time, Jane Shull, and to others a reintroduction. Jane Shull, CEO of Philadelphia Fight.
Good morning, everybody. Good morning, everybody. It's a pleasure to be here with you today. I'm Dr. Stacey Trooskin. I'm the Chief Medical Officer of Philadelphia Fight. I'm sorry we had a little bit of a technical difficulty, but we're really looking forward to being with you for the next session. I think we're going to dive in and get started, but without further ado, I want to introduce my colleague and friend, Dr. Kevin. You're a doctor now, Kevin. Kevin Costello, who is the Director of Litigation for the Center for Health Law Policy and Innovation at Harvard. Kevin is not only an educator and shaper of young legal minds at Harvard Law School, he also is a fierce litigator and negotiator, and I've had the privilege of working with him on not only advocacy case for individuals to access hepatitis C treatment, but and directly negotiating with payers to ensure people have access to life-saving treatment. But I've seen him at work and mentoring young minds, and it's an honor and a privilege to be with such a fierce advocate and activist today. So thank you, Kevin, for joining us today.
Hey everybody, thanks Stacey, and the feeling is mutual. You all know Stacey at Philadelphia Fight for being there in the trenches every day and seeing patients and running a clinic. I know Stacey from watching her fly all over the country to try to help reform healthcare policy in different states. And she is serving as an expert in some of my litigation. And to see her sitting in a conference room being deposed by opposing counsel and watch their cross-examination melt in the face of Stacey's intellect and passion for her patients is something to behold. So I'm really looking forward to spending some time with everybody today. If I could ask the folks to pull up the slide deck, we'll go ahead and start talking about the topic for this morning, which is healthcare as a right and not a privilege. So this first slide is really just a way for me to introduce myself to everyone and to talk about where I'm at and what my mission is now at Harvard Law School. It's a center that grew out of the AIDS epidemic in the 1980s. My shop was started as the first law school clinic in the country to directly serve people living with HIV. And at the beginning of the HIV epidemic, people who were around during that time will remember just the stigma that was associated with the disease, and just how terrible it was to live through that time period, watching people not only get sick and suffer and die, but also to be really cast aside by politicians and by government. It was really a depressing episode in the history of public health in our country. And so this clinic that I work in now was created at that time to serve people living with HIV, and to help them on a whole range of legal issues, not just healthcare issues, but also family law issues, trusts and estates issues, housing issues, the whole range of legal needs that someone living through that terrible disease would require, and also serving their families. And so what is a law school clinic? A law school clinic is it's really built on the medical model. Everybody who has been to a teaching hospital knows that sometimes your doctor comes into the room and they are trailed behind by 5 or 6 other people who are in some stage of their medical training. And so they are sort of having this dual purpose, this dual mission of, on the one hand, they are serving the patient and working on the patient's case. At the same time, they are in the process of doing their own training and their own learning under the supervision of a more experienced doctor. So that's what the law school clinic is, except it's for law students. I am a practicing litigator, and I have a team of law students who are with me as we go through and bring lawsuits that are designed to open access to healthcare, especially for populations who have been historically discriminated against and marginalized. And so, while we trace our roots to the HIV/AIDS epidemic, we now serve a much broader group of individuals and communities who are worried about all different kinds of chronic illnesses, from heart disease and lung cancer to hepatitis C and HIV as well. So let's, one other sort of personal note as we're talking about Philadelphia Fight, I should say that I have a lot of love in my heart for Philadelphia. I started my career, I went to the University of Pennsylvania Law School, which we're going to get to in a minute to talk about the University of Pennsylvania. But I started my career as a legal aid lawyer at a really wonderful place called Community Legal Services. So when I was fresh out of law school, I was spending my time on the Broad Street line, heading up to the corner of Broad and Erie, getting off and going to the office there at 3638 North Broad Street, and serving low-income Medicare beneficiaries who were struggling with accessing prescription drugs in the new Medicare Part D program at that time. It's sort of doubly heartening for me to have a chance to join Philadelphia Fight today, because Philadelphia is where I started my legal career, and it remains close to my heart. So let's go to the next slide and just say, this is what we're going to talk about this morning. This should be a sort of familiar statement to most of you. And what I really want to do is take some, take some time and really delve into what it means and what it doesn't mean, because it's an important rallying cry. Next slide, please. It's an important rallying cry, and you will see it on signs at protests. It is a familiar sort of political rallying cry, and for all of the activists who are in the crowd, it will be something that you all will be familiar with as using as a sort of way to inspire passion of people who are making their voice heard for political change. And so, to the extent that we talk about healthcare as a human right, and healthcare as a right and not a privilege, as a political statement and as a moral statement, I think both Stacey and I couldn't agree with the statement anymore. And that is, in fact, why we spend our time doing the things that we do, and working on the policy reforms that we work on. But there's a reason why you have to show up at a protest carrying a sign that says that. And you don't see anybody showing up at a protest saying like, all of the things that are in statutes are entitled under Section 37 of the U.S. Code, blah 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 blah. Right? It's not quite as straightforward as that. And so I want to spend some time also talking about not healthcare as a right so much as a political statement, but also what it actually means on the ground for people who are trying to access healthcare. So the question around healthcare as a legal right. Let's take a few. I want to take a few minutes, and if you'll indulge me as a kind of history nerd, to talk about, you don't have a right, unfortunately, in this country to show up at a hospital and with a non-emergency condition and say, I have a right to seek treatment for my, pick your chronic illness, my chronic heart disease. You have to go through the registration department, which is going to ask about your insurance coverage. And it's going to ask a bunch of questions about how you would intend to pay for that. How would you intend to pay for that care? Which is different, of course, from emergency care. But in non-emergency situations, the hospital will absolutely sort of stop you at the front door, give or take, and ask you how you intend to pay for the care. So I want to take a minute and sort of dive back into the question of how did we get here? You know, if you live in Canada or if you live in Great Britain or in many of the other what you might call industrialized countries in the world, that is not the case. If you walk in the front door of their hospitals, they don't ask you how you're going to pay for it. They just ask you what you need. And they have a different way of sorting that out. So let's take just a couple of minutes and talk about how we got to where we are. So, you know, we could go all the way back to the beginning. I just wanted to go back, you know, and this is one of my favorite clips because it marks a high, what you might call a high watermark in our history of healthcare as to when did we get closest in our history to having healthcare as a right and not a privilege? What was the moment at which you could say we were the closest to being on the path toward the way Great Britain does it or the way that Canada does it? So let's just take a look at this next clip. It's just a 2-minute video, and it's going to remind us of our own history. I think you may have to hit the play button. Okay, we just go back. We can go back to the Harry Truman card. That's fine. So the answer is the answer is that in 1944, January 1944, FDR gave a speech. It was the State of the Union speech, and what FDR ended up saying at that moment was what he called a second Bill of Rights. The second Bill of Rights was telling the country that they had an actual entitlement to healthcare, to a place to live, to food security. And he was setting forth a vision for our country that if everybody agreed with him and if Congress enacted a law that was consistent with it, then we would actually have a right to these sorts of things, a right to healthcare. And so that was, I would say, you know, if you trace back to where we got into the mess that we're in today, that was a starting point, because during World War II, you know, this is smack dab right in the middle of World War II. You could see that you could see. Hey, can you guys mute yourselves, because I can hear you talking? It's sort of distracting. Sorry. You could see that when World War II was on, the country had come together, and they were sort of pulled together to say, we can do this. It was sort of a moment of high, what you might call communitarianism. People were sort of all pulling in the same direction, and it was America against the world. And it was a moment where we viewed ourselves as a collective identity that was sort of a tidal wave moving forward in terms of societal progress. And so this particular moment of American history was really important to healthcare, because you see FDR saying, in the face of this, we could make it a legal right to have healthcare, right? And unfortunately, there's another thing that's happening at the same time just during World War II. World War II obviously drew a lot of workers out of the workforce and into the military. And so employers were looking for any worker that they could get. And so one of the things that happened economically speaking at this same time is a key moment in healthcare history, which is employers began to include health insurance as an employment benefit. Okay, and when that happened, when all of a sudden you weren't just going to get a salary from your job, you were also going to get a health insurance benefit from your job. It was a way for employers to attract more workers onto their job sites. Once that happened and once that took over, you started to see this tying those two things together at the hip going forward, okay? And once that happened, people became accustomed to health insurance as an entitlement. And once that happened, it forever sort of changed the course of healthcare history, because now those people who were able to have health insurance associated with their job were going to cling to it with everything that they could. And so if we go to the next slide, which is the Social Security card is the next slide, we see that the next sort of stage in this history is that during the Johnson administration in 1965, there was a big fight in our country around Medicaid and Medicare. And it was that Medicaid was largely kind of an afterthought of this. Medicare was really the key thing. And the reason that Medicare exists in the way that it does is because it was intended for people who, just because of what we just talked about, people who had finished their working careers, right? People who were basically retired from their jobs and they still needed health insurance, right? So that's what Medicare was intended to do. Medicare was going to be health insurance for people who had left the workforce, or also for those of you who know Medicare, it also includes people who are disabled or people who have end-stage renal disease or they have problems with their kidneys. So that's what the Medicare fight was about in 1965. But you can see the key thing that's not happening in 1965. It's this huge new program, right? It's Medicare is a big deal, and Medicaid comes along right behind it. At that time, it's sort of an afterthought, but it comes along right behind it. But what's not being discussed in 1965 is, what about everybody else? Why don't we have health coverage for everybody else as an entitlement, as a right? And it's simply because people began to be accustomed to and to people began to hold on to the notion of the employment-based coverage that they had received as a result of that job shortage coming out of World War II. Okay, so if we go to the next slide, moving right along to this moment, which people will recognize who were paying attention in 2010, right? This is Marcellus Owen on the left there, whose mother died because she didn't have health insurance. She was diagnosed with pulmonary hypertension in 2006, and Marcellus there on the left became a healthcare activist as a result of that. So when the Affordable Care Act was signed, which is what's being pictured in this photo, Marcellus was there with the president, and you can see who else is in that photo. You see Nancy Pelosi and you see Joe Biden right there as the Affordable Care Act is being signed. So a key thing to say about this is, again, the Affordable Care Act is I spend a lot of time litigating about the Affordable Care Act and trying to preserve it. But let's talk about what the Affordable Care Act is not, right? I mean, I watched the debate last night. I'm well aware that the Affordable Care Act is under attack from Republicans, and the Supreme Court is going to hear a challenge to it in the next couple of weeks. So I will fight like hell to keep the Affordable Care Act in place. But for the purposes of this conversation, let's talk about what the Affordable Care Act is not, right? The Affordable Care Act does not change the fundamental sort of landscape of what health coverage looks like in this country. It doesn't displace the tens of millions of people who enjoy employer-based coverage, right? And so in that way, it's very much a political compromise. It didn't uproot the previous system. It built around the previous system. Okay, and because of that, it has faced many challenges in how complex its scheming is, and the ways in which it tries to build out towards universal coverage. The idea behind the Affordable Care Act at the end of the day is to take our existing system in 2010 and to fill in the gaps around the edges where people don't have coverage. And it's meant to try to incentivize its biggest, I think, tenet is to expand Medicaid in states where Medicaid had not yet expanded. Expanding meaning make more people eligible for who can get on Medicaid. And so it worked really hard to sort of fill in the gaps around the existing system. What it didn't do is change the existing system, right? That basic system of people getting their health insurance from their jobs remained in place. So the key thing to remember here, and when we return to our major theme about is healthcare a right and not a privilege, is the notion of this existing system as being built really on companies and individuals who are incentivized to make money off of the existing system. So let's go to the next slide here and talk about, for a minute, let's talk about where people continue to have these gaps. So this next slide is a picture of Millie Serpis from Easton, just up the road from Philadelphia. Unfortunately, Millie is in this picture and has been in the press because she is there at her kitchen table looking at photos of her daughter, Monique Gabriel Moses, who died in 2017 at age 26 from complications of type 1 diabetes because she could not afford her insulin. Now, I'll leave it to Stacey to tell everybody what insulin is and how it affects the body. But the bottom line is that insulin is, I think, relatively cheap to manufacture. And it should not be the situation where it is so expensive that people are dying because of not having access to it. Insulin prices have increased sharply over the past decade, and it has become unaffordable for many patients. Studies have shown that prior to COVID, up to 25% of insulin-dependent diabetics were rationing their supplies to save money. And so with the pandemic, the dramatic rise in unemployment and the loss of employer-sponsored health insurance is likely to bring this crisis to a breaking point. You know, this is particularly true in Pennsylvania, where the unemployment rate hovers around 13% and almost 700,000 people are uninsured. So again, the Affordable Care Act was great and it filled in many of the gaps. But here's the thing, because it didn't change the fundamental system, because it could not shake, it could not hold up FDR's promise from 1944 and turn this into a country where healthcare was a legal right that people were entitled to. You're going to have people like Millie Serpis, who lost her daughter because of a basic healthcare need that was out of reach financially. And that is, I think, a theme in American healthcare, and it is terribly unfortunate. So until that basic financial structure is changed, until you figure out how to crack the nut or solve the puzzle of taking healthcare in America off of the basic track of financial incentives that currently exist, whether it's manufacturers, drug manufacturers, or insurers, or healthcare providers, every player in the system is just as concerned with, the financial incentives, because it's not a situation where, as FDR said, the government is going to take it over from the top and turn it into a situation where everyone has a right to the care, legally speaking. So, I feel terrible for people like Millie Serpis, and we serve many folks like her and her daughter in our client base. But at the end of the day, access to Pharmaceuticals, I mean, pharmaceuticals are one of the country's major industries, and millions and millions and billions of dollars have been generated off of this kind of innovation in the pharmaceutical sector. And it's a sort of double-edged sword, because pharmaceutical innovations have caused a lot of good in the world, right? People have been the beneficiaries of really advanced innovation in that sector. I think the problem comes when it gets tied to financial incentives. So let's go to the next slide here for a minute. This is an example of what I'm talking about. So people may recognize this product. It's called, on the next slide here, it's called Retin A. It's sort of a skin cream that's used, I think, both for controlling acne, and also it's an anti-aging cream. It's one of the most sort of omnipresent, it's everywhere, pharmaceutical products that you can get a prescription for. In the first 20 years of its existence, Retin A was prescribed millions of times, with a total sales over that time period more than $250 million, and it's prescribed millions of times a year since then. So the reason I'm raising this Retin A example, next slide please, is to talk a little bit about where it comes from, and how we got to it. So this is a picture of Dr. Albert Kligman, who for many years was up the street from Philadelphia Fight in West Philadelphia at Penn, and was the chair of the dermatology department there. He is recognized as the person or one of the primary contributors to the development of Retin A, and sort of gave Retin A to the world, and became a very, very, very wealthy individual as a result of it, for securing the rights to that product and licensing it out and having it become as widespread as it became. But with Dr. Kligman, you have to ask some more questions, which is how did he figure out how Retin A worked, and how did he arrive at the final product? So let's go to the next slide. For people who have lived in Philadelphia for a long time, you might recognize this photograph. This is the former Holmesburg prison. The Holmesburg prison isn't around anymore. I think the building is still there, but it's not operated as a prison anymore. It's in the sort of lower northeast. And it was the site of some what I think are fairly described as healthcare atrocities that occurred within its walls. So there is an author in Philadelphia called Alan Hornblum, and in 1998 he published a book called Acres of Skin. And what Acres of Skin describes is that from 1950s through the 1970s, this prison, Holmesburg prison, served as Kligman's own sort of, Dr. Kligman's, he called it the Kmart of human experimentation. So when Kligman first saw the imprisoned population at Holmesburg in 1951, he had been called in as a consultant to help curb an outbreak of athlete's foot. And then when Hornblum, when the author interviews him, his quote is, "All I saw before me were acres of skin. It was like a farmer seeing a fertile field for the first time." So he described it as an anthropoid colony, mainly healthy under perfect conditions for controlled experiments. All I saw before me were acres of skin. So Kligman, had a scientific interest, but really at the end of the day, what he put people through over the next 20 years could fairly be described as torture, that he was going to personally benefit from in terms of the licensing of the products that were going to result of it. So it began as, I think, small scale experiments, but over time, it became worse and worse. So let's go to the next slide here. So this is a photograph of inside of Holmesburg Prison, and the range of different experiments that Dr. Kligman and his team subjected prisoners to really turns your stomach. They were subjected to dioxin, which is a powerful carcinogen, and other kind of chemical warfare agents such as viruses, acids, and fungi. There's a quote from the book that says they walked half naked around the prison with bandages crisscrossing them and tin cups attached to their foreheads or below their genitals to collect discharges and sweat. They were injected with radioactive isotopes. Their fingernails were extracted. Their organs were biopsied. They were locked in padded trailers and brought to the center of the prison exclusively for purposes to wrestle with the invisible specters their minds conjuring during psychotropic tests. So, you know, if the government knew what was going on in the 1950s and 60s inside of Holmesburg Prison, they were pretending not to notice, because Dr. Kligman, of course, covered his tracks by saying, "Oh, these are willing participants in my experiments. They have, you know, they're being paid." And they have signed a piece of paper that says that they're willing to participate, et cetera, et cetera. Let's go to the next slide. So this is a picture of Yusef Edwards of Philadelphia. And so Yusef is one of the people who was the subject of these experiments. And he has now told his story about what happened. And one of the quotes in the book says that, you know, first of all, he never made more than $30 for his participation, and he never was awarded a single cent in court. And so the way he describes Dr. Kligman, he says, you know, he was a monster. He didn't see us as human beings. You know, he says that now that he's being able to tell his story, it makes him feel bad because the suffering he's seen within the institution and the suffering that he's been through himself. He says, I don't think Kligman should be held with such honor after the damage he's done to so many people. Because, you know, up until relatively recently, Kligman was still being held up as, you know, the distinguished professor chair at the University of Pennsylvania. And I think that has since Yusef and others like him have succeeded in having that torn down. But it's only with a great deal of persistence and a great deal of advocacy that has happened. So, you know, Yusef's story and what happened inside of Holmesburg Prison is just one example of the kind of skewed set of incentives, the sick and perverse set of incentives that remain in existence at inside of our healthcare system. You know, with respect to this particular problem, I think since the 1970s, you know, institutional review boards and ethics boards have been put in place that have very much cut back the use of human subjects in clinical trials and in pharmaceutical development. But trust me, there are, so long as that financial incentive remains in place, there will always be a push for big companies to take advantage of those financial incentives by figuring out what the next angle is on exploiting people towards those goals. So in some instances, I think, you know, these kinds of maneuvers have moved to third world countries, to move overseas to other places. You know, the world has gotten a lot smaller in the last 70 years. And the bottom line is, until those financial incentives are changed, until we sort of have an opportunity to switch the way the healthcare system is set up and to realize the promise of what FDR was talking about in 1944. It's going to continue in various forms. It might not be the same way that Youssef experienced it. It's going to be somebody else in another setting that has the misfortune to be on the wrong end of that financial incentive. So let's go to the next slide. So this kind of brings us to the point where I want to pull in Stacey to the conversation and just say hepatitis C is an example of these financial incentives being played out right in front of our eyes today because the interaction between the financial incentives that are present inside of the development and sale of hepatitis C drugs and the way that there are sort of downstream impacts on the third-party payers who are responsible for the care and treatment of the people who are on their insurance and coverage rolls. This is an example of we're seeing some version of this story play out again right before our eyes. So it's what Stacey and I are engaged in together, is trying to fight to make sure that people that do have insurance coverage in whether it's Medicaid or whether it's private insurance or whether people are looking to another entity for their healthcare coverage because they are, say, in prison and the 8th Amendment to the U.S. Constitution entitles them to adequate healthcare while they are in the custody of the government. In all of those settings, Stacey and I believe fundamentally that people shouldn't needlessly suffer with a curable chronic illness. And so I'm going to ask Stacey to, now that there's a scientific slide in front of us, I'm going to ask Stacey to jump in here and pick up the story.
Absolutely. So I want to get us all on the same page and just make sure we all know the basics of hepatitis C as we move into talking about this as a case study. If we could have the next slide, please. So when we think about hepatitis C, I just want everyone to remember that this is a disease that can impact the liver. And the risk factors for hepatitis C are coming exposed to contaminated blood. And this could happen, for example, before the blood supply was able to be tested prior to 1992, which if you think about it is really not that long ago. But the most common way that we're now seeing exposure to hepatitis C occur is through injection drug use. And it's not just about the syringe, but it's about all of the works that go along with it, the cooker, the cotton, water, et cetera. And so now that we're in the midst of this opioid epidemic, we're seeing a whole new generation being impacted by hepatitis C. And it is often called a silent killer because only 15% of people who are infected with hepatitis C will experience symptoms around the time that they're infected. And then what happens is over decades, hepatitis C can cause damage to the liver. And this occurs through liver irritation and inflammation. And then after that, that inflammation causes scarring to the liver. And a little bit of scarring is called fibrosis, and a lot of scarring is called cirrhosis of the liver. But I think it's also really important to remember that it's not just about the liver here. There are other things called extrahepatic, meaning outside the liver, manifestations of hepatitis C. And these things include everything ranging from increased rates of depression to inflammation of the muscles, fatigue. There are certain kidney issues, there are certain skin issues that can be impacted by hepatitis C, as well as increased rates of diabetes and heart disease. So even though we think of hepatitis C as just the virus that can cause liver damage, it actually can impact the whole body as well. In 2013, deaths attributable to hepatitis C surpassed the total number of deaths from 60 other infectious diseases that are reported to the CDC combined. So to think that this does not impact public health in a serious way is a gross misunderstanding of this disease and what it means to our communities. Next slide. I have good news for you, though, that we've come a long way in terms of treating hepatitis C. In the past, many of you actually may have heard that hepatitis C is hard to treat, right? We used to use something called interferon and ribavirin, which in some cases, the treatment made people feel worse than the disease did, because this is really like a chemotherapy. It would work by revving up the immune system so that it becomes very activated and tries to kick out the virus. But in this non-specific activation of the immune system, people felt terrible. They would feel flu-like, develop loss of appetite, loss of hair, depression, even psychosis. So these medications were not a great alternative. Folks would need to be on these meds for a year of their lives, and there was a flip of a coin's chance that they would cure their virus after being exposed to these toxic medications. But then something interesting happened. In 2011, the first direct-acting agent was approved. And what I mean by direct-acting agent is this medication acts directly on the viral life cycle, stopping it in its tracks. And the first iteration of these direct-acting agents was used in combination still with interferon and ribavirin, so the toxicity was still there, but now it was no longer the flip of the coin. The odds were in the patient's favor that they would likely cure this infection if they use this. And then 2 years later, by 2013, we had the first all-oral direct-acting agent combination regimens, meaning we're no longer giving injections with interferon, we're no longer having side effects. Simple as one pill, one time a day, we're able to cure 95% of people in just 8 to 12 weeks of treatment. And this is extraordinary. So we're in the middle of a coronavirus epidemic, right, everybody? And so how much would we love a cure for a virus? We're all wanting it, yearning it, love a vaccine, love a cure, right? That doesn't exist yet. And in fact, I cannot think of any other virus that has a cure, with the exception of hepatitis C. We wish there was a cure for HIV. We can control it, but we can't cure it yet. This is a revelation in public health. And I would challenge you all to think that if we had a cure for breast cancer or Alzheimer's disease or coronavirus, would we not be making sure that there was no cost or effort spared in getting it to every person who was impacted by a disease that kills more people than the 60 most common infectious diseases combined? Unfortunately, that hasn't happened. And the reason it hasn't happened is really based on price. When this medication came to market, it was priced around $84,000 per treatment course. And unfortunately, the medication is about 84 days in duration. So if you divide that, it's about $1,000 per day. And the lay press got a hold of this and really raised awareness about the cost of these medications, payers locked down, and ever since, this medication has been rationed, despite the fact that there have been competitors that have come to market. We now have more than one brand of medication that can be used to cure hepatitis C. Prices have dropped dramatically. One cure is now less in price than it is for 1 year of HIV medication. Let me say that again. 1 year of HIV medication costs more than a cure for hepatitis C. So the prices have come down. Pricing should not be an issue anymore, yet we still have rationing. Next slide, please. So the rationing that we're talking about really takes 3 different forms by payers, right? And in many ways too, in the prison system as well, in the jail system. So the way that payers, meaning insurance companies, have been rationing this medication is by disease severity, sobriety, and then prescriber. So let's take each of those one at a time. So next slide. Disease severity is how much damage has been done to the liver over time, okay? And as I mentioned to you all before, a little bit of scarring is called fibrosis, a lot of scarring is called cirrhosis. And we measure this on a scale of 0 to 4. 0, no scarring, 4, cirrhosis of the liver, and 1 through 3 are in between. And some insurance companies are saying, no, you don't get this curative medication until you develop scarring to the liver that is significant. Even though we know that if we give you this medication, we can prevent you from getting any scarring to the liver. So the disease severity piece doesn't make any sense. It is not based in science, and it is not based in any of the recommendations by any of the governing bodies that doctors and other providers listen to. So for example, the American Association for the Study of Liver Diseases and Infectious Disease Society of America has looked over all of the literature, and the science tells us that we should be treating everybody for hepatitis C, everybody. And in fact, the earlier you treat them, the better they do, because you prevent them from developing any of the negative outcomes of hepatitis C. But in fact, if you treat people too who have late stage disease, there is still a decrease in rates of liver cancer and still a decrease in rates of mortality. So treatment works, and we should be making sure that everybody gets it, no matter what stage of disease they have. Next slide, please. The next type of treatment restriction that we see is the sobriety restriction. And there are many Medicaid programs that are requiring individuals to demonstrate sobriety, meaning abstinence from drugs and alcohol. So what I can tell you is this is based in nothing but stigma and discrimination, because again, the science tells us that even people who use drugs respond just as well and cure at just as high rates as individuals who do not use drugs. And there are many providers, just like me, that will say people who use drugs every day. They adhere to medication to make them feel better or stay well. Why would you deny giving somebody life-saving treatment because they also may happen to take another kind of medication that just may not be legal yet in our country? So we are depriving people of life-saving treatment just because they may have a comorbid condition of substance use disorder or addiction. And that is unacceptable. And in fact, is not only bad for the individual, but is bad for public health, because treatment is also prevention. And what do I mean by that? You can't give somebody something that you yourself don't have. So if we cure your hepatitis C, and when I say cure, I mean the virus does not exist in your body anymore. If we cure you, you can't pass that infection on to somebody else. So someone who may be engaging in drug use, who may be sharing their injection equipment with others, it is not only in that human being's best interest to get rid of the hepatitis C, but it then saves anybody else they may be sharing syringes or works with. It prevents them from getting the infection. So there is a public health imperative as well as an individual health perspective here to be considering. Next slide, please. The last type of restriction that we see that rations medication is the prescriber requirement. And this medication is very simple to prescribe. In fact, as a provider who takes care of my HIV patients, diabetes, and hypertension, it is easier to treat hepatitis C than it is to treat any of those other long-term chronic illnesses, right? We can fix the hepatitis C. Yet, there are payers that will refuse to allow a primary care provider to prescribe these medications. Now, you don't need to be an infectious disease specialist like me or a hepatologist like other colleagues in order to know how to prescribe these medications. And what this does is it creates barriers. It creates barriers for individuals who have trouble navigating what is a very complicated and siloed healthcare system. And it also has implications for people who may live in rural communities where there isn't a specialist anywhere nearby, and they have to travel hundreds of miles to get to a place where somebody is approved to prescribe this medication. So we can imagine a world that is free of hepatitis C. We have the tools to eliminate this virus from our communities. We have a cure, we have testing, right? But what we have done is effectively created barriers that are rooted in discrimination, stigma, and cost savings. And we have gotten in the way of our ability to have healthier communities and provide life-saving treatment. So next slide, please. So Kevin, I think I'm gonna open this up to more of a conversation between you and I around some of the federal guidance to the states and their position on why some of these rationing techniques really get in the way of healthcare as a right and not a privilege.
Yeah, so I'll just say, we can tell a little bit of the story of, I think maybe the Pennsylvania example is a good one, but just to take a few steps back and to tie it to the larger issues that we're talking about here today about is healthcare a right and not a privilege. Because of these fundamental sort of institutional actors being cemented in place as to where they are, the pharmaceutical companies did a great thing here, and they developed a cure. As Stacey says, it is a revelation. You have third-party payers, including many state governments, right, who then end up pointing their finger. Everybody's pointing their fingers at each other to say the state government saying it costs too much, and the pharmaceutical companies are saying, well, we need money to research and development for the next cure of the next thing that we're working on. And so, again, all the players are in place, and they're all pointing at each other. They all have their own sets of incentives and concerns and lookouts. It just reminds me that this system that we're in is just fundamentally broken in its infrastructure. So in the meantime, what do Stacey and I do? In the meantime, we see that this cure exists. We see these restrictions and these obstacles being put in place. So we decide to fight like hell to get people access to the drugs, right? So if you go to the next slide, you'll see in 2015, one of the first steps that we took was to advocate, a prior slide, was to advocate at the federal government level to say, hey, the federal government, have to tell the states that they need to cover this drug in your Medicaid programs. And so that was an important first step. And then we had to go state by state by state to each Medicaid program and say, hey, you are not covering this adequately. So Stacey and I memorably went to Harrisburg and advocated at the Medicaid Drug Utilization Review Board. It's a group of people that gets brought in by the state Medicaid program to make specific coverage decisions around specific drugs, and they take public input. So we went and yelled at them about their failure to cover hepatitis C treatment adequately in Pennsylvania's state Medicaid program. And with a lot of patience and a lot of persistence and a lot of advocacy by Stacey and others, the Pennsylvania Medicaid program, I'm happy to report, relented and removed the fibrosis score restrictions that that were previously in the Medicaid program for Pennsylvania. So that's one victory, and it's that's the nature of the fight that's in front of us, is going sort of payer by payer, state by state, and making the change. And so Stacey and I continue to do that. We're currently engaged in a little bit of a tougher fight in the state of Texas to do that. So I'm recognizing the time, and I'm thinking maybe we want to allow the opportunity for questions, and then also for the closing remarks.
I wonder, Jane, if you have any experience from your advocacy work early on in the HIV epidemic that may inform some of the thoughts about this process and the challenges that we're having with hepatitis C medication.
Yes. So we're sort of beyond some of the stuff that I wanted to say to tie this together, but I do think that it's important to recognize that the essential problem that faces Americans now because of our healthcare system, that it is so tied to work, was evident during the AIDS epidemic. I mean, what we saw during the AIDS epidemic, during, the earlier years, and what I think actually still goes on, is that unless you worked for a very large institution like government, you probably would lose your insurance because you would get sick. And in addition, as the epidemic went on and the rules in Pennsylvania changed so that every every company was, would get their own rate, you know. When a small company would start to fire people because of increases um, in their health insurance rates, right? I mean, this was morally wrong, but economically sensible. We knew it. It took then 30 more years, I think, before the idea got attention. One of the reasons that the idea of healthcare for all, human right, Medicare for all, whatever you want to call it, has been the relentless advocacy of Bernie Sanders and then the relentless advocacy of Elizabeth Warren, which I think caused people to think about this. But the other thing about this is there's, a lot of people now in this country who see it because of COVID, and because we're at a moment in American history where the idea that's now called Medicare for all has been out there. The connection, I think, has been made. And I think that the activist community should bear in mind that we have more of an opportunity here, particularly if Joe Biden becomes president. We have more of an opportunity here than we had before, with people who have very specific stories, who people who did lose their insurance, of people who had reason to be concerned about losing their insurance, when it turns out now it's not just AIDS. But I mean, I think we knew that. But the other thing that I want to say, since when Asada was introducing me before, she mentioned that I taught social work at various places for a long time. The discussion in social work has always, and what I taught was social policy, right? The discussion in social work is like, is it policy or is it power, right? Well, it's both. But the other thing that I think is essential to understand here about this history, which I will say really fast, is it is not the case that Lyndon Johnson did not intend to go on. Joseph Califano, for example, other people have written memoirs. They did intend to go on. The Vietnam War happened. It drove Johnson from the White House. He was replaced by Richard Nixon. Richard Nixon began the corporate takeover of medicine. That's what happened. And we should call this, as they say, by its name, because it was under Nixon that the first HMOs, which became MCOs, and so on. And what happened after that is that the insurance industry, which was not as heavily, the for-profit insurance industry was not as heavily into healthcare as they are now. They saw their opportunity and they took it. And the opportunity that they saw was, oh, look at all this money we can make. And the way they took it is they became, all over the country, the largest or occasionally the second largest donor to everybody in state legislatures and everybody in Congress. So in fact, they're all owned and operated by the insurance industry. And one of the mistakes that Bill Clinton made was believing that the insurance industry was popular. And so he developed a health plan, that was going to take them, that was going to help them, right? And he did that because he thought that because the insurance industry was really popular in Congress. So, there is no way to be too cynical about this. In fact, I think we're probably not cynical enough. But I do think that, the experience and actually the activism of AIDS advocates, many of whom national AIDS advocates were profoundly involved in the last effort, which did save the ACA. And all those people wandering around the halls of Congress were not just using the tactics of AIDS activists, they were the AIDS activists, and they broadened their perspective and so on. So it's important. There's a moment here. And it's important that activists take advantage of this moment. The families of 212,000 people who died, the families of people who recovered, the people who have partially recovered and cannot go back to work, who's insured. I think there's a possibility that people can see it, but I'm also saying we need to be cautious and not believe that the reason that anybody is opposed to what is obviously what should happen and happens in every other country in the world, right, and all that stuff, is because they have some policy idea about it. No, they're getting donations. That's, you cannot be too cynical about this. And I also just want to say one thing that would have come from from my intro. We are incredibly lucky at FIGHT that Stacey is here and is our chief medical officer, and we are incredibly lucky at FIGHT and ICJ that Asada is here and is the director of ICJ, and she also has just done an extraordinary job, and people should be aware of that.
Thank you so much, Jean. I really appreciate that. We appreciate, the perspective that you offer to this discussion. I know I speak on behalf of Asada and myself. We love to be able to do the work that is so mission driven that you have set out intentionally for this organization. So thank you for that. I want to make sure that we answer a couple of questions in the time that we have left. We have a couple of viewers who have written in questions. So for Deborah, she asks, what about people who continue to wait for meds because they've been told their disease must progress more? What should we do about this? And so I think, Deborah, that is an amazing question. I have certainly my perspective, and I know Kevin can offer perspective as well. The first is that, at least in the state of Pennsylvania, if you are writing this question in and you're a resident of Pennsylvania, nobody should be waiting for medications based on disease state anymore, not based on payers anyway, at least for most Medicaid patients. And I have not seen a private payer like an Independence, Blue Cross, Blue Shield. None of those folks that I've seen have denied anybody based on disease severity. So my concern is that patient is being told that their disease is not severe enough by a provider, which is even worse, I think. And so the first thing I would do is make sure you advocate to that individual to get a second opinion and to make sure that another provider has tried to ask the insurance company for medication, because we need to be making sure that we are, as providers, treating everyone following the AASLD IDSA guidelines and getting everybody treated. Now, if we find that a payer is not willing to pay in the state of Pennsylvania or somewhere else, I would say as a provider, we should be advocating and using our voice to provide that payer with as much data as possible, to ask to speak to the medical director and ask them to rationalize for you as a provider why we are not following the standard of care when it comes to providing hepatitis C treatment. So the provider should be taking on a bit of that role. And then Kevin, I wonder if you can offer some guidance from a patient and a legal perspective as to what also can be done.
Yeah, absolutely. I mean, it's highly, as you indicate, it's highly context specific. Just to say, there is almost no setting in healthcare where you don't have some version of a right to appeal that kind of coverage denial. And so whether it's inside of a managed care organization where you could take an administrative appeal, or whether it's a state Medicaid program, Medicare, private insurer, almost always some version of the right to appeal. And obviously that appeal is bolstered if you have professional advocates in your corner, including attorneys who are dedicated to this kind of work. And so, I'll point you to to my own website, which is chlpi.org. It's CHLPI.org. And then you can also look at, if you go to the stateofhepc.org, you can see whatever state you're in will be covered on that website, and it will tell you all the information you need to know about what the current coverage restrictions are in your area. So reach out wherever you are, find a lawyer who can help you and get that thing appealed.
Excellent. Thank you,
Do we
Kevin.
have other
And
questions?
then we do. I think we have time for one more question here, and it's a sort of a heavy one for you, I think. Hopefully we can get through it in the 5 minutes we have left. But one of the viewers would like for us to comment on the impact of the Supreme Court appointment, or the impact of the Supreme Court decision determining that incarcerated population is the only population in the U.S. with a right to health care. Are you able to interpret that?
I think that it's an interesting, I'm not sure, we would have to have a little bit of a colloquy to get to the bottom of this question, but I think what it's suggesting is that Estelle versus Gamble, which is an older Supreme Court case, and what it does is that Supreme Court case says that if you are in the custody of the government, because you're in prison or in jail. In jail, it's a little different if you have not already been convicted, but you have a right to be free from deliberate indifference to serious medical needs. Deliberate indifference to serious medical needs. That's the legal standard. So I don't know if we can call that a right to health care. I mean, it certainly, it's a different context, because obviously when you're in prison, you don't have the ability to seek your own care. You don't have control over your own movement and your own physical situation. So it's really a basic level of human rights that when you are in that sort of a setting, whoever does have control over your physical circumstances is responsible for making sure that your serious medical needs are attended to. So I mean, there is a way to sort of characterize that as a basic right to healthcare. So that's true. But I think one of the things that you learn, especially in the current environment, about what's happening in federal courts all the way up to the Supreme Court nowadays, is that it is increasingly hard to turn that standard into meaningful healthcare. So just to take the hepatitis C example, Stacey and I have been fighting all over the country to have state corrections departments recognize a basic right to hepatitis C treatment for everybody who is imprisoned in their state. And I would say in the cases that Stacey and I have been involved in, it's been quite successful. But again, it's a case-by-case basis. There are the trend, especially over the last 6 months to 1 year across the country, in cases that Stacey and I are not involved in, has been to shut that down and to say it's perfectly fine for a state corrections department to withhold treatment for people at lower fibrosis scores who have hepatitis C. That does not violate this deliberate indifference to a serious medical needs standard that the Supreme Court set out in the Estelle versus Gamble case. So is it a basic right to health care from the Supreme Court? Yes, I think that's fair to characterize. In practice, is it as robust as we think is warranted? Absolutely not. And that's why it requires an ongoing fight, an ongoing advocacy to make that right mean something on the ground today and going forward.
Excellent. Thank you. Thank you, Kevin, so much for joining Philadelphia Fight today and offering your wisdom and breadth of experience. We were lucky to be able to learn from you today. Asada?
Thank you so much, Kevin, Dr. Trooskin and Jane, for your comments. I have to say, as I was sitting listening to both of you speak, it occurred to me that oftentimes when one is heavy credentialed, as you both are, they lack the ability to speak in layman's terms and to make things understandable for someone, just a quote unquote, a normal person. So I just want to thank you so much for speaking in layman's terms, and your passion for what you do certainly exuded. Kevin, I kind of chuckled as you said how Dr. Trooskin is in courtrooms throughout the country, and I, knowing her as I do, would hate to be on the other side of that witness stand as she is bringing forth testimony. So thank you so much, Kevin, for your extensive overview of Dr. Quigman. I had no idea about that history in Philadelphia, and so it both saddened me and reminded me of the tragedy that existed oftentimes in our history with Black and brown persons being used as subjects. So thank you again for going into that and shedding light on that. I concur and I agree that affordable health care is absolutely necessary. 18,000 persons die a year due to preventable diseases. And so as we continued our march and our stance for social justice, I thank you both so much for agreeing to be on here today. You did not disappoint. And again, each segment was chosen with intentionality. Dr. Stacey Trooskin, as always, thank you. Thank you, Kevin. I learned so much from you today. And thank you both for your work that you continue to do for persons who don't have a voice to speak for themselves. Thank you. I want to go back to our CEO, Jane Shull. As Dr. Trooskin said, we are able to do what we do because of what Jane did before us. And so our work is rooted in advocacy and activism that was done way before either Dr. Trooskin or I turned up at Philadelphia Fight. And so again, it is my pleasure to reintroduce and to introduce our CEO, Jane Shull, who is at the helm of Philadelphia Fight. And again, as a result of her commitment, advocacy, determination, and demanding social justice for HIV, that ICJ was subsequently birthed. And so we will close out this segment with closing comments from our CEO of Philadelphia Fight, Jane Shull.
Thank you, Asada, and thank you, Stacey and Kevin, for a really interesting and enlightening discussion. And I am really glad that we are able to have this kind of programming during the COVID epidemic and still do a prison summit. And I think, the staff of ICJ under Asada's leadership really deserves our thanks, and PhillyCam for helping us out also really deserves our thanks for making this possible. I mean, we have for many years, as Asada said, been working on advocacy and tying our, we offer services, this has always been our goal. We offer services to people who need them, but we also advocate for the larger changes that we need in our society, so that hopefully those services will be available, to everybody. We've been working in the Philadelphia prison system for 20 years. And the way it started was in another presidential year. In the year 2000, the Republican National Convention came to Philadelphia. Unlike in 2016, when demonstrations were treated as peaceful, in 2000, this civil disobedience that started to happen, and then anybody who kind of looked to the Philadelphia Police Department as if they might intend to be part of a demonstration, people started getting picked up and sent up to the Philadelphia prison system. Before that convention, I had talked to some of the younger activists who, of course, they're now people in their 40s. This was a long time ago. And I said to them, do not organize these demonstrations under the name of Philadelphia Fight. Don't use our phone number. Don't use our address. Don't do it. And of course they did anyway, which I knew they were going to do, but they used a slightly different address. They didn't use our phone number. They had a coalition and so on. But there were people in our circle who had never been incarcerated, who got picked up and guarded off to jail. Two, very notably, Jackie Ambrosini, who was the head of YHEP, the Youth Health Empowerment Project at the time, who had no intention of being arrested and got arrested because she stopped to witness an incident of police basically assaulting a demonstrator. And when she left, she said, like, you didn't have to push my bike, whereupon they arrested her. And she stayed in jail for several days because there were a lot of young kids in the jail, and Jackie was very worried about them. And if you did not give your name, they wouldn't let you out. The other one was Laura McTighe, who was one of the two founders of ICJ. Laura got arrested, came out, said, something, we need to do something about this. And I said to her, daughter of a doctor, I said to Laura, part of the problem is that unless people who have the advantages that she had in life are willing to kind of be poor for a while and just work on making change, it doesn't happen. So she quit her small after college job with the caterer and she went and founded ICJ. But then we also need to remember the other person who was there in that mix, who was John Bell, who had been arrested, who had spent time in jail, who had acquired HIV somewhere along the way, and who was one of the most extraordinary organizers and extraordinary human beings that I have ever known in my life. And there would be many other people who would say this. So Laura and John formed a partnership and created ICJ basically out of that. I mean, there's another storyline, which is that we at FIGHT had many people who were part of, the revolving door, getting picked up, ending up in prison, coming out of prison. But without their leadership, this program really would never have started. And when John tragically died of complications related to his HIV 8 years ago, this year, and Laura went on and she's now a professor teaching, training a new generation of activists in Florida. And then Hannah Zellman, who had been working here, also took over and did an extraordinary job running the program. But then that kind of brings me back to where we are now in ASADA. And the thing that I do feel it's important to say when we think about the history is FIGHT has succeeded in part, but ICJ has succeeded really entirely because when we have had leadership that can project an authenticity of I have walked in your shoes. John Bell was able to do that. And because of that, there are people all over Philadelphia who will be able, who do still say that John Bell was the reason that they are sober yet today. ASADA, who has shown commitment and compassion and who's really creative and truly determined and who listens to the people who come into ICJ, has brought us back the authenticity that we lost at the death of John Bell. And I have to say, till ASADA came along, I hadn't quite figured it out either, but she did. And I think the other thing that I want to say about ICJ recently, and during the COVID epidemic is, we have 200 and something employees, and so there's going to be different reactions and so on, more than any other group of employees here, because they didn't have to. The people in ICJ ran toward it. I mean, I was talking to ASADA, what I'm saying to ASADA, you got to tell people they can't go up to the prison. This is and she's like, well, I can't stop them. And then the prison locked down. So they found other things to do. They went out, they found people who were in need, they got food donations, So it's the whole team. It's the whole team that is working sort of with our clients and our participants and our guests. And ICJ has really exemplified that from the beginning, still exemplifies that, and ASADA exemplifies that as much as anyone in its history. And she has also been able to bring in many, many new programs and collaborate way more effectively with Dr. Trooskin and the programs that we our medical program. So I think we're all really fortunate. We're really fortunate at Fight that we have this kind of extraordinary support, and it's important that we acknowledge it. And like here we are, 20 years later, and we're still doing this. So thank you.
Thank you so much, Jane. Thank you. Thank you so much. Dr. Trooskin, again, thank you. Kevin, thank you so much. We are going to begin to transition into our the rest of this session, and that is artist resistance. And if you have been watching the last couple of days, we have viewed some phenomenal artwork through the lens of social justice and different artists' view. Before we do that, though, we have been speaking about the Man Up Association out of SCI Phoenix, who we have partnered with, and we are the extension at ICJ with the Man Up Hub. And we have been speaking of one of the co-founders, Tyree Wallace, as we anticipate hearing from him from behind the walls tomorrow. We, however, are going to hear from the other co-founder, Anthony Sutton, today. He, along with Tyree Wallace, founded Man Up. And so I thought that it would be wonderful to hear as well from the other co-founder, as it is a result of their vision that we are able to be an extension of the Man Up Hub here in Center City at ICJ. Thank you so much. Here's the video.
Section of Man Up. We had 65 men come over to the chapel and pay respect to our vision and what we seen was need to be done in our community. The crime, the killing, the elders not being treated right, the children can't play, and our women being killed. So we came down here and we called for the men to come down. Not only listen, go back and pick up the phone and call a friend and tell them from this day on we're going to man up. We're going to women up. So moving right along, Miss Thomas, she used her influence and she had politicians come to ICJ here to speak with us men and bring their resources that we can give these men housing. We can give these men jobs. We can also teach these men it was another way. All they had to do was believe in themselves and get out their way. So on that note, we went from 65 to 175 to 475 men. 2 sessions, 16 sections of Man Up. They came down here, black, brown, and white. It wasn't no color barrier. It was a man thing. It was a woman thing. Because we had some powerful women came here, judges, police inspectors, councilmen, also our number one supporter that we had coming up every other week was Tracy Fisher. And Diana Sealy had the opportunity to come with her own eyes. Her and Mr. Al. We cried together. We grew together. We also said enough is enough. So now let me give you a little bit. We did skits. We had music. But we also knew that we had to use our influence that we had. These men looked it up to majority of us. So we had to use what we have established over the years in these camps. We gave these men another view about life. So we start talking about our community. And why is these sensitive killings going on in our community? Why is our babies' blood is running through the streets of Philadelphia? The mothers is crying. The babies is dying. We said enough is enough. So Lamar Stewart from the DA's office came and had the opportunity to bring 4 members with him. A. Thomas said he would bring Mr. Larry Crafton to sit down and speak with us about what's going on in the city of Philadelphia. And he was so impressed with the vision of Man Up lives, saving our babies, and having an impact in our communities. So how do we do that? We had a plan of 50 men, and we are playing with these 50 men. You will hear from the men of Man Up as they tell you the part that they play in Man Up. But my job and duty is to MC Man Up. And after seeing my child coming right here with his father, it cracked the atom within inside me that I knew that I had to stay on this path and make a change. The hurtful thing for a man to see is his child to come and be with him inside of a penitentiary. Not only do he look like me in a spitting image, he picked up some of my negative ways. So I had to show nothing but positive in his presence. Even though he might look up to me for all the wrong reasons. But this day, I choose to man up. And I choose to man up because we got to save the lives of our babies. Our young women is being killed in the streets of Philadelphia. Children from the age of 10 to 25 is being shot down in the streets of Philadelphia. So we blowing the trumpet. We calling for the missing men to get back in our community and stand up and be who they say they are. Only way that this gonna be done, that you have to place men that's participating in Man Up, that's willing to put their lives on the line to